Hello, this is Dr. Thomas again. Today we're going to be discussing another important component of liver function tests, namely bilirubin. We're going to be discussing the physiology, pathophysiology, and clinical relevance. First of all, disclaimer. Bilirubin, as you know, is an yellow-orange bile pigment resulting from the catabolism of heme. It serves as a central biomarker in the evaluation of liver function, hemolysis, and biliary obstruction. A thorough understanding of its metabolism and the mechanisms leading to its evaluation is essential for diagnosing and managing jaundice and hepatobiliary disorders. Physiology of bilirubin metabolism. Bilirubin originates from the degradation of heme-containing proteins, mainly hemoglobin, but also to a certain extent cytochromes, myoglobin, catalases, and peroxidases. Daily production averages approximately 250 to 300 mg per day in adults. Heme oxygenase in macrophages converts heme to biliverdin, which is then converted to unconjugated bilirubin via biliverdin reductase. Transport of bilirubin. Unconjugated bilirubin is lipophilic and water insoluble, transported in plasma, tightly bound to albumin to prevent neurotoxicity and renal excretion. Hepatic uptake. Unconjugated bilirubin dissociates from albumin and is taken up by hepatocytes via organic anion transporters. Conjugation. Bilirubin is conjugated within hepatocytes. Unconjugated bilirubin is conjugated with glucuronic acid by UDP glucuronyl transferase to form mono and diglucuronide conjugated bilirubin. Conjugated bilirubin is water soluble and non-toxic. Excretion. Bilirubin is excreted actively into bile canaliculae by MRP2 transporters, delivered to the small intestine, converted to urobilinogen by gut flora. Majority of this urobilinogen is oxidized to stercobilin, which gives stool the brown color and is excreted in feces. Minor portions of urobilinogen is reabsorbed into the enterohepatic circulation and excreted in urine as urobilin. Unconjugated bilirubin, otherwise known as indirect bilirubin, is lipophilic and is albumin bound, not excreted in urine. On the other hand, conjugated bilirubin, otherwise known as direct bilirubin, is hydrophilic and minimally bound to albumin but excreted in urine. Total bilirubin is the sum of direct bilirubin and indirect bilirubin. Direct bilirubin measures conjugated bilirubin and some amount of delta bilirubin, which we'll talk about later. Indirect bilirubin is calculated by subtracting direct bilirubin from total bilirubin. Pathophysiology of hyperbilirubinemia. Prehepatic causes of hyperbilirubinemia, which is mainly unconjugated hyperbilirubinemia and is due to overproduction or impaired conjugation. And following are some of the main causes of unconjugated hyperbilirubinemia. Number one, hemolysis due to autoimmune hemolytic anemia, hereditary spherocytosis, G6PD deficiency, conditions associated with intraerythrocytic parasites such as malaria, conditions associated with ineffective erythropoiesis such as thalassemia and megaloblastic anemia, Gilbert syndrome due to decreased UDP glucuronyl transferase 1A1 activity, Crigler-Najjar syndrome, which includes Crigler-Najjar syndrome type 1 and type 2. Type 1 due to absent UDP glucuronyl transferase 1A1 activity, and type 2 due to decreased activity of the same enzyme. The laboratory findings include elevated indirect bilirubin, normal transaminases and alkaline phosphatase, reticulocytosis, increased LDH level, and decreased haptoglobin level in blood if hemolysis is present. Hepatic causes of hyperbilirubinemia gives a mixed pattern due to hepatocellular injury, impaired uptake, conjugation, or excretion. Conditions associated with this hepatic causes of hyperbilirubinemia include acute viral hepatitis, drug-induced liver injury as happening in acetaminophen toxicity, and toxicity due to isoniazid, and other hepatotoxic medications, alcoholic hepatitis, autoimmune hepatitis, and sepsis-related cholestasis. Characteristic laboratory findings include elevated AST and ALT, mixed elevation of indirect and direct bilirubin, and variable elevations in alkaline phosphatase and GGT. Post-hepatic causes of hyperbilirubinemia, which is mainly conjugated hyperbilirubinemia, include conditions associated with cholestasis or obstruction. Post-hepatic causes can be classified broadly into extrahepatic causes as happening in choledocholithiasis, pancreatic heart carcinoma, and cholangiocarcinoma, and intrahepatic causes as happening in primary sclerosing cholangitis, primary biliary cholangitis, and infiltratory disorders. Characteristic laboratory findings in post-hepatic causes of hyperbilirubinemia or conjugated hyperbilirubinemia include elevated direct bilirubin level, elevated alkaline phosphatase and GGT, dark urine, pale stools, and pruritus. Special situations and syndromes include Gilbert syndrome due to decreased UDP glucuronide transferase 1A1 activity. Key features include intermittent jaundice associated with fasting or acute illness. Gilbert syndrome is a benign condition. Crigler-Najjar syndrome type 1 due to absent UDP glucuronide transferase 1A1 activity and is associated with severe jaundice and increased risk of neonatal kernicterus. Crigler-Najjar syndrome type 2 due to significantly reduced activity of UDP glucuronide transferase 1A1 activity and the jaundice associated with this condition responds to treatment with phenobarbital. Dubin-Johnson syndrome due to MRP2 mutation leading to impaired excretion of conjugated bilirubin and associated with direct hyperbilirubinemia and black liver. Rotor syndrome characterized by impaired storage and excretion, and key features include features similar to Dubin-Johnson syndrome but no liver pigmentation. Approach to the patient with jaundice. Assess clinical features. Duration and progression, pale stools, dark urine, pruritus, and systemic symptoms such as fever and weight loss. Order initial labs including total bilirubin and direct bilirubin, transaminases, alkaline phosphatase and GGT, complete blood count, reticulocyte count, LDH and haptoglobin. Imaging studies such as right upper quadrant ultrasound should be the first line imaging studies for suspected obstruction. MRCP or ERCP help getting detailed biliary imaging. CT and MRI scan help with identifying structural problems and oncologic evaluation. Clinical correlations. Dark urine and pale stools suspect conjugated hyperbilirubinemia. Unconjugated bilirubin is never found in urine as unconjugated bilirubin is transported bound to albumin and water insoluble. Alkaline phosphatase and GGT elevation way more than AST and ALT suggest cholestatic or obstructive process. Isolated hyperbilirubinemia with otherwise normal LFT should raise suspicion for hereditary syndromes or hemolysis. Important clinical pearls. Number 1, always fractionate bilirubin. That means find out direct versus indirect bilirubin levels in the setting of jaundice. Gilbert syndrome is the most common inherited cause of isolated indirect hyperbilirubinemia and recognized to avoid unnecessary testing. Number 3, bilirubin more than 20 to 25 mg per deciliter in neonates increases the risk of kernicterus. In adults, extremely high levels should prompt evaluation for hepatic failure or massive hemolysis. Number 4, ERCP is diagnostic and therapeutic in biliary obstruction but carries certain risk. MRCP is preferred if intervention is not immediately needed. Delta bilirubin is conjugated bilirubin covalently bound to albumin, may persist for weeks after obstruction resolution, is important in follow-up interpretation. Unexplained conjugated hyperbilirubinemia with mild LFT abnormalities should prompt consideration of Dubin-Johnson syndrome or Rotter syndrome, especially in younger adults. The following are the references. Thank you for listening.